Hi, Dr. Sherman. So we have a few minutes between patients. Can I ask you a few questions? I was doing these exams and I'm finding it difficult differentiating between dementia, depression, and delirium.
Yeah.
Can you help me out?
Yeah, absolutely. So when we talk about these things, we're really looking at kind of the big high yield things are time of onset, right? So when we talk about something like delirium, usually we have some sort of acute change that you can kind of pinpoint or point your finger at and say like, oh, like they're different now potentially because of this one change, but it's acute, it's recent. Yes, of course, you can have things like protracted delirium, but usually there is an inciting event and it's fairly recent and it causes an abrupt change in their functioning. When we talk about depression, we start to talk about kind of a more or less 2 weeks to a month, right, of kind of gradual change in their presentation. Usually with voiced low mood, usually with some degree of withdrawal, anxiety, things like that. But it is a little bit longer time of onset. That 2 weeks to a month is pretty typical. And then when we talk about dementia, Yuri, we're talking about a more insidious time of onset. Can be months to years even, where people have a gradual, sometimes very low detectability onset of some of these changes that then become clinically important when they reach a certain tipping point in their functioning. Does that make sense?
Yeah, makes sense.
So the other things to be really mindful about is kind of how do they look when they're having this presentation. So delirium, acute onset, and then you also have these other hallmarks of delirium, which are waxing and waning sensorium, so changes in level of alertness that can happen over hours to days. Usually it's more consolidated than that, though. Usually there's kind of multiple fluctuations within a day. So those two things, and inattention, this like inability to focus on what is happening around you and increased distractibility. So they'll be talking with you and then they'll be paying attention to something that's happening over there or rapidly fluctuating back into kind of lower alertness. Those things are certainly more consistent with delirium. When we start talking about depression, we can have voiced low mood. So usually you'll be able to ask people who have depression if they feel depressed or sad or low, and they should be able to answer in a confirmation type of way. They can also have apathy, amotivation, anhedonia, so lack of interest and enjoyment in things, decreased speech output, slowed movements related to their depression, even to the point sometimes of having, catatonia.
Yeah.
So these things happen with depression. Then we talk about dementia, where people have this insidious onset of change in their executive functioning, their ability to retain new information, and then progressively losing more recent information. So short-term and intermediate memory are impairment, issues with planning, issues with visual spatial functioning, issues with like verbal output and verbal fluency, decreased ability to engage in their own self-care, and certainly like the memory issues, forgetfulness, etc. So when we start to look at some of these things, right, time of onset, and some of these characteristics can also allow you a better ability to differentiate some of these issues, delirium, dementia, depression.
Yeah, but they kind of seem similar. Like I'm wondering, like the patient we saw this morning, like the confusion, for example, or the lack of concentration or attention. I feel like if someone is delirious, depressed, or demented, they can have these. I'm just finding it difficult to just differentiate when I see the patient.
I will tell you that teams will feel the exact same way that you feel. They feel frustrated because sometimes it can be very difficult to differentiate these things, especially in a hospital setting. This is where a consultation liaison team. This is the fun of it for us, where we get to sit down then and really do some of the things to start to differentiate this. So certainly chart review is important, but what if they don't have a thorough chart history here? I think the most important thing that we can speak to about this is collecting collateral information, right? If they have direct family, that makes it so much easier to collect collateral, because then you get really time of onset. Was there an insult that resulted in this? Have they been feeling more depressed, more withdrawn? Did they have a psychosocial stressor that resulted in them having depression? You can start to put that together. Okay. What if they don't have that? Well, you can we've had to do things like talk with neighbors before. We've had to do things like talk with staff at assisted living facilities or skilled nursing facilities to really start to differentiate this. But collateral, I can't speak enough to the importance of collateral. The other thing that I would say is to be able to really look at doing a thorough medication reconciliation. So we prescribe medications, and especially in older populations, people get prescribed innumerable meds. If you have cognitive issues, whether that's from delirium, whether that's from depression, whether that's from dementia, sometimes you can mix up your medications and take the wrong ones. Sometimes you forget to take your medications. Sometimes you are prescribed medications that other providers might not know cause significant issues with cognition. And so doing a thorough medication reconciliation can involve things like talking with a facility, talking with a family member to see if they're giving them their medications or if they're worried about them overtaking them, calling a pharmacy to see when they had these things recently given. Because the other thing that can happen is people come to the hospital, no one does a med rec, they get started on something that they were prescribed 5 years ago, and that's the inciting event for their delirium. Okay. So thorough medication reconciliation, collateral context, I can't speak enough to the importance of that. If you find that it's still difficult to differentiate this, right, you can always do things like standardized cognitive testing. St. Louis University Mental Status Exam and the Montreal Cognitive Assessment are usually pretty good to find maybe what domains they're having deficiencies in. And then also, when we're looking at this, doing the appropriate medical testing to rule out things. So things like hypothyroidism, low vitamin B12, they can all cause issues with whether it's mood related or whether it's a neurocognitive appearing. They can all kind of mimic and mirror some of these presentations too. So looking at that, do they have a reason or a cause for their delirium? Certainly that's kind of the hallmark, because if you treat that, hopefully the delirium then resolves. So finding causation for delirium, evaluating to make sure that you're not missing causation for things like depression and dementia can certainly put you, I think, on the right path to being able to do some of this differentiation. And again, collateral, med recs, make sure that you're doing those all the time.
It seems like there's a lot of investigation to do, and then figuring out if there's an underlying condition and trying to treat it first. Like an underlying reversible condition and trying to treat it first. And then maybe that would help us discern. And
again, it's remembering the times of onset as part of your differentiation when you're thinking about it. Really zooming way out and trying to establish that. And certainly some of these can put you at risk for each one, right? So dementia puts you at increased risk for developing delirium. So you can have both, right? Depression can also put you at risk for developing delirium. Severe depression, people can actually have, some deterioration in their functionality that puts them at risk for developing delirium. So sometimes people can have all of them at once. You can still differentiate it by time of onset and time to change.
Awesome. Thank you.
Absolutely.